Good morning, good afternoon, and good evening, everyone. We are about to start our first Health Systems Governance and Financing webinar. The webinar will be introduced by Dr. Agnes Soucat, and then we will have Abdo Yazbeck as our main speaker. We will have two discussants, Kurfi Abubakr, who still have to join us, and Irpo from Cambodia. And then a long session with all of you, questions and answers. We'll have plenty of time. So it's a 2-hour webinar. But actually, you will see that Abdo has a very reasonable and not too long PowerPoint. So we hope it will allow us to have a very thorough discussion. The wrap-up will be done by Kutzin. My name is Bruno, and I will do the facilitation of this session. So I leave the floor to Agnes. Agnes, the floor is yours.
Thank you very much, Bruno, and welcome to everybody, wherever you join from. So this is really my privilege to introduce this first webinar out of a new series that is launched by the Health Financing and Governance Department of the WHO. And really happy to start with today with a set of very distinguished speakers and respondents, but would like to start with a bit of introduction on this new series and what we are aiming to do. What is our motivation for this webinar series? We know that progressing towards UHC will be the achievements of the fact that a multitude of relevant knowledge is widely distributed. We hope that our webinar will contribute to consolidate a supportive ecosystem for the global crowd experts working on health system governance and financing. So it is about knowledge, and it's about ecosystem of knowledge. For our own contribution and impact, our health governance and financing group embraces a comprehensive approach to knowledge management. We organize meetings, we publish reports, we do policy briefs, articles, we manage global database, we organize courses, and we thought that in the world that we are living with the massive changes in the way people interact today, in parts partially related and accelerated by the COVID-19 crisis, we felt the need of a webinar series. So we also acknowledge that because of COVID, the movement restrictions will persist for a while, so that this will affect our capacity to meet all of you face to face. So this webinar partially aims at replacing a lot of the activities that we had anticipated and planned jointly with many of you. So what is our commitment? 6 main added value of this webinar series. First, we really want to focus on depth of knowledge and having high quality sessions, focusing on emerging issues, ongoing processes, new analysis and findings, but also tools and solutions. It's a series that is anchored in country experience and country reality. So it's a series that is co-developed with the WHO regional offices and WHO country offices, which are part of the regions. It is happening in partnership with other UHC actors. It will be specific to the sessions, and that will include all the major actors in health financing, particularly the World Bank, with a very broad participation during the session and in the question and answers. We will focus on visibility and continuity. So webinars will be disseminated, but also the discussion will be expanded and deepened through social media, blog, and recording. And really, what is probably the most important, we want this series to operate on a learning mode. Your feedback will really help to improve us and to really respond to what you see as your knowledge needs. This webinar series has an editorial board. So it is a one WHO webinar series, which includes people from the regions. We have representatives from each regions, as well as representatives from headquarters, from different fields of governance and financing. So how do we start And what are we going today? So today is very special. It's very special for the webinar series because we are launching it and we want to start with one of the most critical topics at the crossroad of health financing and health system governance. Today, we're going to talk about social health insurance and the way it is financed with a particular focus on labor taxed finance social health insurance. It's fundamental as a topic for both financing and governance. Financing because it is a mechanism that has been broadly used over time. It's probably the first mechanism that has been used as a UHC financing instrument back a long time in Bismarck's Germany. But it's also a governance issue, as social health insurance has developed many models of participatory governance and collaborative governance with different stakeholders in societies, particularly employers, employees, and other groups. Today is very special to me also because I'm really delighted to welcome one of my very dear friends, but mostly one of the most well-known health economists in the world, Abdo Yazbeck, who led recently a commentary in Health Affairs together with different authors from academia, WHO, World Bank, and others on the question of labor tax financed social health insurance. And Dr. Yazbeck, who has a PhD in economics and has worked more than 2 decades at the World Bank, has both experience in many different regions in the world, including South Asia, Africa, Europe, and others, but also has worked at in different capacities in the World Bank, both having hands-on experience in projects as well as working in developing some seminal work on health equity and health financing. So really happy to welcome you, Abdo, and have you present this very important article that summarizes the experience with labor tax finance social health insurance. Just want to finish with acknowledging our partners today. This series is operating in partnership with the Social Health Protection Network, P4H, which is the Global Health Financing Collaborative, and with the network of emerging voices for global health, bringing into the discussion our broad network of practitioners that are working on health financing and governance at country level. We also have our 2 discussants with us, and Bruno will introduce them in more details. And working in the background, we have Bruno Meessen, who is facilitating, and Joe Kutzin, who is going to help us with the wrap-up. I just want to finish with some special thoughts for one of our co-authors of this paper in Health Affairs, Adam Wagstaff, who unfortunately passed away recently. And I really want to dedicate both this particular seminar, but the whole series to him. Adam was a giant of health economics. He led global work on equity, on financial protection, on generally all aspects of health economics. And for all of us, he remains a person that we aim to follow the path of and to emulate, and he's really greatly missed. And a lot of what is in this article of Health Affairs and a lot of the depth and the quality that comes in this article is related to Adam's very crystal clear vision and deep and extensive knowledge of the issue of financing universal health coverage. So really dedicating this to Adam. Thank you very much. And let me hand over to Bruno to present our 2 discussions.
Thanks, Agnes. Well, we will have 3 contributors. So the first one will be Abdo. Abdo will present you the paper just mentioned by Agnes. Then we will have Irpor. Irpor is based in Cambodia. Irpor has been doing a lot of work on, he's medical doctor. He has a PhD, a master's in public health. He has done a lot of work on health financing and is, among others, published a lot on health equity funds in Cambodia. And then we will have Kurfi Abubakr. Kurfi is from Nigeria and he worked for the National Health Insurance and he is also an emerging voice. Abdo, the floor is yours.
Good morning, everybody, and thank you very much for the very kind introduction, Agnes. I'm happy to talk to you today about this paper that was published in May in Health Affairs. It's a labor of love in many ways. As Agnes said, this was a piece of work that was very close to a lot of our hearts. We all loved, revered Adam Wagstaff, who we lost the same week the paper was published. But I wanted to highlight one thing in it. The title itself is fairly negative, and I'm going to talk about that. It's a case against labor taxes, and that's by design in my case. But what I'm very proud of is the ability to bring so many thoughtful people into this conversation. So in addition to myself, I'm now with Hopkins, but I had a career at the World Bank. Bill Savadoff was sort of the main driver of the topic itself. Bill is currently with the Inter-American Development Bank, was with WHO Geneva for a while, and that's when he wrote a seminal piece in health policy and planning on this exact topic using the Latin America experience. I'm gonna get to it. He's back now with the Inter-American Development Bank. Bill Shao, a famous long-term Harvard University professor. Bill used to be the chief actuarial of the United States government, has given advice to presidents of countries like China and elsewhere, and Colombia, is a pretty well-established leader, thought leader in health financing. Joe, which you'll hear from today, probably the most well-known health finance economist, leader of the health finance group at WHO. Agnes Soucat, who you just heard of, the director of the program, incredibly thoughtful, has been active in topics that are incredibly important on governance as well as financing. Ajay Tandon from the World Bank, probably the least well-known in terms of his name, but if you've seen any fantastic graphic on health financing in the world, it was most likely started by Ajay. He also knows more about understanding health financing and the fiscal space than anybody I'm aware of. Adam Wagstaff, as Agnes mentioned, was the global leader on health equity, was the president of the IHEA, International Health Economics Association, and was a long-term manager for research at the World Bank. And finally, not least, Winnie Yip, the current president of IHEA and a professor at Harvard. So the reason I'm proud of this is to get so many people with lots of ideas to agree on a negative topic was a major achievement. And it should raise points to people who read the paper or engage. This is not a thought piece that's meant to just get conversation going. This is a strong statement about something we know, and I'm gonna focus on that as we go forward. So the presentation outline, a little bit about the motivation, why we needed to write a negative paper, a little bit about, Agnes mentioned that social health insurance is probably the earliest health financing system we're aware of. It started, to the best of our knowledge, in 1880s in Germany. Otto von Bismarck was the chancellor. But it has changed quite a bit over the 100+ years. And this change is actually quite confusing, because a lot of people think they're talking about something when they mention social health insurance, but which something they're talking about. So there'll be a slide, I'll go through these changes, the evolution, and why it creates some confusion. I'm gonna then talk a little bit about why so many thoughtful people thought it was a bad idea, even as back as 20 years ago, and published about it. And then the heart of the paper is, we have noticed it's coming back. It's coming back with a vengeance. And we're trying to understand why. Is there new evidence that we missed in the 1990s that's justifying why this idea of labor taxes to finance social health insurance is now gaining strength in low-income countries? And finally, close with a take-home message. So, motivation. I title it Bismarck's Unfortunate Reemergence. It's a blog I wrote a couple of years ago, and I'll provide you the link to it later on. Something surprised me 5 years ago. I was still working at the World Bank. I was managing the East and Southern Africa work program, and I started getting this comments from my staff in the field saying, this country is starting a labor tax social health insurance. This country is starting or interested in a labor tax social health insurance. And I couldn't understand why, because to most of us, this was settled science. It made very little sense for low-income countries with small labor markets that are formal in nature to start a formal sector labor tax social health insurance. And so as I started talking to colleagues, Ajit Tandon at the bank and others, I started hearing that it wasn't just in Africa. In Southeast Asia, there was an interest, again, in fairly low-income countries or low middle-income countries in building a labor tax social health insurance, again, under conditions that didn't make sense. 2.5 years ago, I left the bank. I took early retirement. I joined a large project funded by USAID, and I started seeing more and more requests for technical assistance for countries interested in initiating a labor tax social health insurance, low-income countries, Haiti, Togo, elsewhere. And it's, again, I could not understand. So I started a conversation with some colleagues, and they told me, Abdo, you're exaggerating. I tend to exaggerate things. I'm Mediterranean, I'm emotional. Maybe I saw 5 countries and I thought it's the world. So I decided, fine, let me do a survey, let me do a scan of all low and low middle income countries. And so we looked at as many countries as we could reach experts in to understand, is there interest in this labor tax social health insurance? Everybody said, I'm exaggerating. So I thought maybe 20%, which would be bad in my view. And then the scan happened, and to our shock, well, the good news first is we were able to capture 41 of the 48 countries, which is quite sizable to get so many low-income countries to talk to experts in it, to understand what is it they're trying to do. Now, the survey looked at more than insurance. It looked at all reforms, but I'll focus for this presentation only on the one question. Are these countries considering initiating labor tax social health insurance? To my shock and horror, we found that 60% of these countries, 25 out of 41 that we were able to reach experts in, have initiated or are considering initiating a labor tax social health insurance, which shook me because, again, it was considered among health finance specialists as settled science that that's not necessarily a smart thing to do, based on, as you'll see in a minute, on the Latin America experience and other experiences. And so that got us wondering 2 things. Why? And second, and the second part is the origination of the paper, maybe we're just too arrogant. Maybe we've missed this completely. Maybe there is new evidence that we missed in the 1990s. So the first question, the why. So we reached out to 8 countries out of these 41 and asked the experts, why? Since there is no clear evidence for this being a good thing to do for low-income countries, why are they considering this approach to health financing, initiating a labor tax social health insurance in countries with very small formal sectors? And we got 4 consistent answers. The first one, and I apologize for the acronym DRM, it's one of my least favorite acronyms in health finance, which stands for Domestic Resource Mobilization. Turns out a lot of donors in health want to get out of funding health as external partners and are putting pressure on countries to initiate more money for health. So this term, domestic resource mobilization, has become a main driver in many countries. And so that is one of the biggest reasons why countries needed, under pressure from donors, to initiate ways to generate more money for health. And they saw that as a good way of doing it. The second is what I call a misunderstanding of the C in universal health coverage. A lot of people seem to think coverage means insurance coverage. And I leave it to Joe Kutzin at the end to correct me if I'm wrong, but my understanding of the WHO creation of universal health coverage is the C in coverage relates to effective coverage of services and not necessarily insurance. So the C relates of getting services to people, not how to finance it. In fact, my understanding is WHO is agnostic about how money is generated. But anyway, a lot of countries felt that C is coverage for insurance, and therefore this is a good thing to do. There's also a desire for financial autonomy. Countries' ministries of health feel under the thumb of the Ministry of Finance. Every year they have to negotiate a budget, but they also have to follow the rules of procurement, very limiting rules of procurement. So having your own funding, which you manage through an insurance fund, gives, at least they feel it gives them more autonomy to make decisions. And they may be correct about that. And finally, it is attractive to a lot of politicians. Providing insurance is seen as an entitlement. And therefore, it's something that you could argue you're doing for people. And they may be correct about that as well. So those were the 4 reasons we found. Let me now take a step back and walk us through a brief history of how this instrument and the financing part of it has changed. And the first sort of, sorry, it keeps, here we go. The first part of it is what I call traditional social health insurance, TSHI. And by that, I mean as close to the origin of this instrument, which is you have people pay either fully by the employee or shared between the employee and the employer, a premium, and that premium entitles the worker and the worker's family, in most cases, to a benefit package, a package of health services that are financed through an insurance fund. So it's that important link between a premium being paid through labor taxes most of the time that entitles families, in most cases, to a benefit. And that was initiated in Germany, and as far as we could tell, in 1883, taken on 600-700 years of guild-based insurance. So you had these guilds, those groups of workers that work in similar professions, creating insurance systems to protect themselves. It started, I think, mostly as life insurance. So when somebody passes, the family gets support. And then it grew to things such as unemployment insurance, as well as health insurance. And so in 1883, Germany's Otto von Bismarck, part of the approach to unify the country, began this process to create this, what now we refer to as traditional social health insurance. And it took Germany 127 years to achieve universal health coverage. That model then caught on in Europe. And so you have Belgium, Austria, and others following on. And of course, it took time for them to achieve universal health coverage. Then the same model or versions of it took up in East Asia, first in Japan, which I believe achieved universal health coverage over 60 years ago, or close to 60 years ago. South Korea was the fastest in terms of getting it together. They're not identical, but the basic elements of mostly financed through labor taxes, and then providing an entitlement to workers of a health insurance benefit existed in them. Then there was a huge experiment in the 60s in Latin America, in which most middle income, low middle income countries in that region at that time initiated this basic form of labor tax social health insurance. So that's think of it as phase one, the traditional labor tax social health insurance. Then came very interesting changes, and I'm going to walk you very briefly through them because it's important to understand what we now call social health insurance comes in different forms. America and the United States, they started two very different forms of insurance. One I would not even call social health insurance, but many people confuse as it. But both of them have this unique issue of delinking labor taxes from the entitlement. So if you think of Medicare, which again in the 1960s, basically it was a recognition in the United States that many elderly people, mostly no longer in the labor market, were impoverished and had no access to health insurance, since in the United States, health insurance is linked to employment, something most health economists think is a terrible idea, most economists think is a terrible idea, but that's the dominant form in this country. So this model of Medicare was generated so people like me who are in the labor market now pay a part of our labor taxes to finance health insurance for people who are 65 or older, who are mostly outside the labor market. So that link between the labor tax and the benefit started disconnecting. Medicaid is entirely different. It is for people of any age that simply are not able to participate in health insurance because of poverty, because of employment status. And in that case, there's zero link between labor taxes and health insurance. So it's not even close to it, a traditional social health insurance, but many people confuse it as a form of social health insurance because the words social and health insurance are in the title. In this case, it is social because it's financed by the government. It is health insurance, but it's not what typically we identify as traditional social, because there is no premium paid by the workers or the employers to pay for the benefit. There's zero link between. So it started this delinking completely. Interesting thing happened since World War II. If you look at today at an OECD health financing scheme, at all the countries of the OECD, there's a wonderful chart which I usually use, and it shows you half the countries rely heavily on labor taxes, half the country rely heavily on general revenue taxes. Well, if you look at the history in Western Europe, you'll see that increasingly countries moved away from labor taxes. Started in the UK, World War II, Italy, Sweden, Denmark, Greece, Iceland, Portugal, Spain, moved away from dominantly a labor tax financing to a general. And even countries that remain dominantly labor taxes, France, Germany, over the years have been hedging, have been adding other sources of financing and diluting the reliance on labor taxes. Interestingly, you do not see a country moving in the other direction in Western Europe. You do not see countries moving from, since the 60s, moving from general revenue towards labor taxes. And you should keep that in mind. Even wealthy countries, which you'll see in a minute, has all the conditions for a successful labor tax social health insurance, are not going there. They're moving away from it as much as they can. Keep that in mind. That is an important point. And finally, there's been this incredible innovation, which started, as far as I could tell, in Colombia in 1993. And Bill Chow, who was one of our co-authors, was part of that. And then followed up in Mexico and elsewhere, which is what I'm calling the extended social health insurance. And this is where we're also increasing this delinking from labor taxes, because in Latin America, you have this fragmented system of people in the formal sector financed through labor tax social health insurance, but people in the informal sector having no direct health insurance, but rely on public financing in public hospitals. In Colombia, they started by saying, let's add people to the insurance, but have that be subsidized either 100% or very large percentage by general revenue. So what you're doing is you're taking a basic element of labor tax social health insurance, and then you're adding people who are either poor or in the informal sector by giving them insurance without linking it to their labor taxes. And that again dilutes this whole idea of a labor tax social health insurance. And finally, and our focus is now we see a new push in Africa, Asia, and elsewhere for going back to the 1883 model, which again is very confusing for many of us. Why are we going back to a model which started 100 and I don't know how many years ago, in which most countries are trying to move away from? But yet we're seeing these countries initiate labor tax social health insurance. And that's the focus of our work. So I said earlier that there were some rejections in the 1990s. These are papers that were published in the early 2000s. And I'm going to talk about three of them very briefly. Bill Savadoff, our co-author, who had worked extensively on Latin America. By the time he moved to Geneva to WHO, he was trying to warn people about the Latin America experience of this labor tax social health insurance. And his main message, and a fantastically important piece that came out in Health Policy and Planning 2004, which we've all been teaching since then, is that the Latin America experience tells us that this system of financing produces this rare combination of inefficiency and inequity. It fragments the system both in how it's financed and it's how delivered. It also puts pressure on informality. It's not necessarily a good lesson. And in fact, most countries have been struggling to find a way to fix their health financing system. And so the strong message that came out in this paper is be very, very careful if you want to initiate a labor tax social health insurance. Unfortunately, that message was lost. I'm going to jump on across the middle one because I have a slide for it next, but I'm going to go to the Wagstaff piece. Again, our colleague Adam, who passed away. When we started getting this pressure in Europe, in Eastern Europe, to shift to the German model after years of general revenue financing, Adam wrote a couple of fantastic papers. I only highlight one, and the links are available for all these papers. Later on, we'll make them available to you. And he basically analyzed the experience of in labor tax social health insurance. And his main message is there's really very little evidence of any added value or success from using labor taxes as a way. And he even identified many of the challenges. So you really could not find publications or evidence that supported labor tax social health insurance, especially for developing countries. And yet it appears that some donors still like it. And I honestly don't understand why. So this is the middle paper I mentioned. This is a fantastic book, actually, that was put together by Bill Chow, Harvard University, our co-author for this commentary, as well as Paul Shaw, who was then at the World Bank. They looked at the European and African and Asian experience with labor tax social health insurance. And they said, okay, if you want to do a labor tax social health insurance, here are the conditions for success. You have to have a large formal sector employment. You have to have high wages and salaries. You have to have low levels of poverty. You have to have small families and household sizes, efficiency functioning network, and on and on. And what I put in X's on the right side is, are these conditions existing in low and low middle income countries? And consistently, none of these success factors or conducive factors for a successful labor tax social health insurance exist in most low and low middle income countries. So again, the messages from the late 1990s, early 2000s is really there's little evidence that this works. So when I reached out to all these smart people, all of them much smarter than I will ever be, and I asked a simple question. I see this incredible emerging demand for knowledge about labor tax social health, the traditional social health insurance. Maybe we are missing something. Maybe since the 1990s, we fell asleep as health financing people. And maybe there's a lot of new evidence that tells us we were wrong. And maybe that's what countries are picking up on. So that was why we decided to do this research and why we wrote the commentary. We wanted to ask a simple question: were we wrong? If all these countries, 60% of low-income countries, are considering this approach to financing that most of us think is a bad idea, what are we missing? So fortunately, our co-authors have been doing a lot of work. So Ajay Tandon, working with a number of colleagues at the World Bank, put together this incredible book called Going Universal. And they responded to WHO's call for universal health coverage and said, okay, let's learn from successful experiences in 24 countries. And if you see the book, it's a good chunk of the world are covered here because these are some of the largest countries in the world. And let's see what are we learning about what works in growing universal health coverage, in achieving universal health coverage. What works in including the poor access to healthcare services. And I'm going to only focus on the chapter that Ajay wrote, which focuses on health financing. So from these 24 countries, successful cases of moving towards universal health coverage, what can we learn about health financing? And again, the message was overwhelming. For all 24 countries, when you look at successful countries that increased coverage for the poor, all the financing came from government, general government revenues, not from labor taxes. So there's very little evidence, actually no evidence, that labor tax social health insurance was used to increase coverage of access to services for the poor. There has been use of the extended social health insurance, Colombia, Mexico, and elsewhere, as I mentioned, but that was fully subsidized or mostly subsidized general revenue taxes on top of an existing labor tax system. So this whole point that labor taxes could be a push towards universal health coverage, we found zero evidence of it. Okay, maybe that's too high a bar. Maybe a simpler bar would say, okay, maybe we can use labor taxes, traditional socialism, for at least to increase domestic resource mobilization. You know, maybe the poor will get access through general revenue, but maybe by increasing revenue for health, we are likely to increase the pot for everybody, sort of a rising tide lifts all boats. Is there evidence of that? And here I turn to Joe's team, Joe's and Agnes's team. Fantastic paper we published in Health Systems and Reform 2018, and a commentary that came by the team with Joe, Ajay from the bank, Christoph Grafsky from the World Bank, Michael Barwitz from the Global Fund. That paper and the commentary made an important finding. They looked at all available evidence of increasing resources for health. And what they found is that successful expansion of resources to health comes mainly from macroeconomic changes. So a country is growing. In a few cases, reprioritization. So countries saying like Vietnam or Thailand saying, we're gonna increase priority to health. And in even fewer cases from efficiency enhancements. They did not find a systematic set of findings that you have increased resources for health through earmarked taxes such as payroll or labor taxes. So again, we cannot find actual evidence that increasing labor taxes has played an important role in a number of countries in increasing domestic resources for health. Finally, another question I'm always asked, okay, so we don't get universal health coverage, but at least let them start with something easy. At least let's start building. And if you build it, then the coverage comes from other sources. So at least don't get in their way of actually initiating it. So, okay, that's a legitimate point. Then the question becomes, can we find experiences in which you did start small and then you grew it? And again, we can't find any. We published a fantastic paper, again, in Health Systems and Reform, in 2018 from brilliant Kenyan researchers who looked at the Kenya experience. Kenya is one of the earliest African countries to explore this labor taxes. They started it in the 1960s. And so it was a good opportunity to see, okay, can we see this, build it, and then grow it approach to health financing? And their main finding, which I highlight here, despite initiating labor tax social health insurance through their hospital insurance system, in 1966, by the time the paper was published, 2018, only 14% of the population was covered. So a 50-year failure of going this, if you build it small and grow it, will it happen? So as you could tell from my general demeanor and emphasis, we could not find cases that tell us, at least justify this recent excitement about Bismarck's model of labor tax finance social health insurance. There is no empirical evidence, there's no experiential evidence that says that since the 1990s, some successes exist which can justify this recent uptake. We unfortunately found more evidence of what we knew in the 1990s, were the problems with labor tax social health insurance. And I'm going to close on some of those main messages. Most of the success factors, a large formal sector labor market, low levels of poverty, capacity, do not exist in low income and low middle income countries. It does actually cause a negative impact on the economy. If you tax labor, employers and employees don't like to pay taxes. So it actually increases pressure on informality. So agreements happen. There's quite a bit of evidence from Colombia, from Mexico, from elsewhere in Latin America, where this taxing of labor to finance social services has put pressure on employers and employees to agree to work outside the formal sector. And that is not a good thing for the economy. It tends to fragment financing, and in the Latin America experience, fragment delivery. So you're increasing inequality and you're creating a two-class system for financing and benefits. Not necessarily a good thing to do. It increases inefficiency and drives up costs. And a very surprising finding and disappointing finding is when you look closely at these labor laws, you'll find that they tend to cover curative care, hospital services, curative care, but not primary and preventive care, which they say, oh, that's funded by public health. So in fact, it moves health financing to the least efficient forms of health financing. So one element of this fragmentation is that you actually end up funding more of the least cost-effective types of services away from primary and preventive care. And there's very little evidence that it increases domestic resource mobilization, which is, again, the main motivation for why we're doing this. Let me now suggest two questions for discussion, but I'm happy to, and my co-authors, Agnes and Joe, I'm sure will be happy to answer any questions about what I presented or the paper. And again, what we presented here is just a part of the paper. The paper is available for free for download. And so we highly recommend that people download them and download the paper and read it. My two suggested questions, but again, I'm happy to take on whatever questions and discussion people take, is since, why are some health financing approaches like earmarked labor taxes and other so-called innovative financing schemes so popular, given this lack of evidence of success? This is a big frustration for me. I keep seeing this term innovative financing, and I have no idea why it excites so many people. First of all, a tax is very little innovative about it. It exists for a long, long time. There's all this talk about bonds and social bonds, and is there evidence for it? In fact, when I looked at the literature, this is not only to health. environment, education, roads. So this dream of innovative financing, earmark taxation, exists in so many sectors, and yet the evidence is non-existence of it being useful or sustainable. The second question I have is sort of a critique of us as a community, global health community. We seem to have a very short memory. Every time there's a global economic recession, we relearn this very simple fact. Health financing should never be linked to employment. It's a bad idea. It's a bad idea in the United States. And if you don't trust me on this one, look at what's happening because of COVID. Countries that rely on employment and labor taxes for insurance for health are in deep trouble now that unemployment is going up. Same thing happening when the financial crisis hit some years ago, 2007, 2008. It's a terrible idea to link financing critical services such as health to unemployment, because employment is cyclical. It goes up, it goes down, and therefore it's not a steady form of financing. And yet in global health, we keep forgetting this important message. We seem to have a short memory, and then we get excited again about something that we know does not work. Finally, and I've put this into a PDF, which will be shared with you. Everything I presented here is based on published papers and blogs that you can have access to. Everything's outside the paywalls. So you'll find the paper itself, the first link. You'll find a blog I co-authored with Bill Savadoff at the Inter-American Development Bank, which brings in this whole idea of COVID, how COVID has made our paper even more relevant. A blog I wrote a couple of years ago, Bismarck's Miraculous Unfortunate Reemergence, the World Bank book, Going Universal, the papers I mentioned from the WHO team, and the fantastic commentary in health policy and planning that Bill Savadoff wrote in 2004, the fantastic paper Adam Wagstaff wrote in 2010, and the recent publication from the Kenya team.
Thanks, Abdo. So this is Bruno. Thanks for this very good introduction to your paper, and I think also comes quite some strong statements also. They are already generating a lot of questions, and we will have a very rich discussion. Abdo, just before giving the floor to Irpor and to Kurfi, someone asked, can you give a clear definition of labor tax, actually?
So it's either called payroll tax or labor tax. So basically a percentage of your salary is taken off from before you get it. So whenever I get my paycheck, I look at it and it has pieces of the money that I'm supposed to get that have been withheld by the employer to be sent to the government. In my case, they would take money that goes for my Social Security, money that would goes to my unemployment insurance, and money that would go to other forms of taxes. So that's money I do not see. You know, so let's say my salary is $100. Most of the time, I only get maybe 60% of that. The other 40% is withheld and sent to government in a form of a tax on my labor to pay for my income tax contribution, my health insurance contributions. In the United States, the amount that's withheld from my paycheck goes to my insurance, but also goes to the insurance of people who are 65 years or older, the Medicare. And so my labor taxes finances my own insurance as a premium. Of course, my employer puts some money in it as well. So I don't 100% finance my insurance. The employer pays a contribution. And then my labor tax also pays for people who are 65 or older to finance, subsidize their insurance.
Okay, thank you. So just to make clear, you are of course not against labor tax. Everybody should contribute to the funding of the government, but it's this linking of the labor tax to the entitlement and the health insurance. Now I will give the floor to Por. So Por is our first discussant, and I really, my guidance to Por and Kurfi was to challenge actually Abdo, because we want to have a very rich discussion. So Por, can you unmute yourself and share your assessment or your reflection on this contribution by Abdo and colleagues?
For the introduction and also for inviting me to this great event. It is my great honor to be the discussion of this event, and also to have the opportunity to discuss with all these global great leading health financing experts. I agree, you say my role is to challenge them, but as you can see in their experience, their privilege, it's hard, you know, and also their rigorous work presented as presented by Dr. Yazbeck is really quite rigorous. They pick up all the evidence and literature and everything. So it's hard to really find a room to challenge them. But anyway, let's bring a couple of issues that can be perhaps allow us to better understand really their conclusive message in terms of position toward the labor tax, social health insurance, and perhaps also to bring a little bit some more evidence around the low and lower middle income country context, where I have been living or going and learning about that may be slightly different from what they have seen from the literature. And then also a couple of facts that perhaps allow us a better reflection toward a better solution. First, I must admit that I totally agree with the author of the paper. It's maybe also safer to say that. Agrees in the point that they convey a clear message that or flagged policymaker, country policymaker, that don't over relying or paying too much attention on labor tax, social health insurance as a health financing source or source for financing so universal health coverage, and may also by doing so may also undermine or divert attention to the more important or great potential general taxes as a source of healthcare financing or financing UAC. This is really clear, and I have no doubt to agree with that. But at the end of the page, you also presented, Abdo, is that when you say that this is not a potential solution, it's not even a solution, and it has contributed very little or not at all, or even harmful to the system. And then you say that general tax revenue can be an alternative and perhaps something that the government should pay more attention to. This is a little bit kind of contradict, like A is not a solution, why B is a solution, but to me, B is not a real solution. I mean, based on what I know about a low-income country or a lower middle-income country context. So we know that macroeconomic work done and show clearly that the basic healthcare needed it's really underfunded in many of these countries, and it never be sufficient in the shortcoming even by 2030. And especially in a country solely relying on general tax, I don't think it will be there at some stage. So the general tax is good, but it needs also other alternative or other complementary solution. And it was not clear to me that when you recommend a kind of a more regulated social health insurance or health insurance premium, that was not clearly laid out in the paper. But anyway, let's go back to the discussion about the social health insurance and the labor tax social health insurance in particular. To me, in low-income country with a very limited fiscal space, and you know that the tax collection capacity is also limited, and general tax revenue really will not be a standalone or a single solution to UAC financing. So this country, perhaps in general, what we have seen in a general trend, they need a kind of a combination. So what are the other combinations they can think about? And one of that is the social labor tax, social health insurance that they have used and combined it very often. And of course, there is very limited of this mechanism as a standalone. But they have been there in the complex system with the complex interaction, and perhaps also outcome that it's not easy to disentangle the effect and also to prove it. And it's clear example, like in Thailand, you know, this kind of labor tax, social health insurance has been there for so long, even long before they reach UAC. Until they reach UAC, you can say that, okay, the last point, time point that they reach UAC was not really thanks to labor tax. It's mainly general tax, but then labor tax also contribute to that, you know. Let's think about mixed health financing system and kind of way to complete the building block of this mixed health financing system toward UAC. So to me, I still had labor tax, social health insurance, although it's not an ideal solution, have very limited potential for many reasons you stated out. It still play a role in the system. And is it really wrong to start to initiate it or further expand it? I think the answer perhaps depends. And obviously, as your question, why it's so popular? Because the policymaker can just adopt it as a law and then can get it done and quickly can obviously see another piece of a batch of funding come to their hand to do a little bit extra things, although maybe not really leading to the desired outcome, but it's there. For example, in Cambodia, I think after the introduction of this employment-based or formal sector employer worker social health insurance, we easily get another extra 50 million US dollar as compared to the total general tax $300 million per year for the health sector. So it's not really small, it's quite big, but we don't have evidence whether it's really helpful, but it's really a big part of money coming immediately after the introduction of such a scheme. And looking at the contribution, also hard. Also, I don't have any literature to evidence that labor tax, social health insurance play an important role in the complex health financing system in low middle income countries. But if you look at the general way of moving or progressing toward UAC, one building block of the formal sector, although they are not really big, but they are also a block to be completed anyway. And this block, as you said, it's relatively wealthier than the other block, but this population group in many Asian countries or low income countries, they are not really wealthier. Many garment factory workers in Asian countries, they are paid less than $200 a month. So without financial real protection, they also end up with financial catastrophic and maybe also deny access to a larger extent. And we have always very rich evidence that social health insurance, if well designed, it will provide financial protection to the members at least. And I agree that it does not allow cross-subsidization or positive cross-subsidization to the poor. But at least we have a solution for this group, which is also have there as the building block to be completed anyway. And then also perhaps relieve some burden of the system for this group rely on general tax, or to take share of general tax and leave the general tax to cover all the population group which is more higher priorities. So then at the end, you know, this building block together, I think the matter is also how we gonna implement it. So implementation also matter. To me, in low-income country, it's like a kind of a set menu you need, and then in this set menu you need the dishes of labor tax, social health insurance anyway. Although many experts may not like this dish, but it has to be there. I think in general it has to be there, except they have very largely generated general tax revenue to provide a general universal entitlement. That maybe we cannot challenge, but in many low-income countries like Cambodia, the system is really underfunded. So we have to find all the possible means, you know, to go. And one is the law, it would go. I would not try to defend labor tax, social health insurance, but I try to identify a couple of conditions under which perhaps social health insurance can play a role in these complex building blocks of the mixed health financing system toward UAC. So this is perhaps what I can say. And then finally, perhaps I can also conclude that the maybe more relevant way to discuss is perhaps to go a little bit further from labor tax, social health insurance is not good, and then general tax revenue is better, but then it is not sufficient, and how? So to me, also the process of implementation is also matter a lot. So I would say that instead of looking for one or the compared to other, maybe think of combination of all these possible means, including even labor tax, social health insurance, and then change a little bit the way we introduce or we move toward universal health coverage, as laid out clearly by a colleague from Africa, I think Eric, in the African health block. He is providing a kind of suggesting the kind of sequencing of the building block, you know, toward social health insurance as well as the UHC financing. And this can be also gradually built up by perhaps instead of starting as usual with easy to reach population, maybe considering the other way around to start with the most difficult to reach population, the poor and vulnerable. Like the case in Cambodia, you know, we started with the poor, with the health equity fund, and then gradually, you know, expanded to other population group, and at the same time also ensure that there is a pact or part of financing available, either demand side or supply side approach to finance the system to ensure the supply quality of services. You know. Thank you very much. So I would like to end my point.
Thank you, Paul. So a lot of points, but Abdo, we start to follow the questions raised by the participant, and indeed, quite a few participants would recommend us to think in terms of complementarity and whether it's still possible to have complementarity. People agreeing that labor tax is certainly should not be the main way to go for UHC, but what could be its role in terms of complementing other funding. And this was a bit the case brought by Paul with the example of Cambodia. Kurfi, you are with us. We invite you to intervene now.
So thank you very much for the invitation, and good afternoon to all, or good morning, afternoon, and evening to our participants. First of all, I want to say that the discussions today have actually achieved the purpose they want to achieve, which is to generate and deepen the discussion surrounding the sources of funding with regards to financing health insurance globally. What I want to say is that having read the paper, there was a very fundamental question that was asked by the writer, which is, will the initiation of labor tax social health insurance advance UHC? For me, first of all, to say the answer to this question is neither a yes nor a no. Categorically, you cannot say that the labor tax does not lead to any progress towards universal health coverage. We have to leverage on the peculiarities of nations, especially those of us in the lower middle income countries. That's one. Number two, we also need to understand that most Africans or lower middle income countries operate what we call silos kind of system. So the formal sector exists in silo. The informal sector is also another silo. And there is little or no coordination or complementarity between the two systems. So sometimes most nations try to start with what they call the low-hanging fruit, which is the formal sector. They try to start with the one that has easy administrative potential, the one that is easy to get, just so that rather than doing nothing, at least you are doing something. You are moving at least towards universal health coverage at one step at a time. The third point I want to highlight is the issue of the comprehensive. I want to appreciate the fact that the general tax system is actually more comprehensive in terms of mobilizing resources. However, we need to appreciate some challenges that lower middle income countries face, which mostly border on the issue of the inefficiencies that exist in trying to raise taxes, as far as lower middle income countries are concerned. Also, if you look at the dynamics of trying to, there are a lot of privileged groups that tends to bypass the tax system in lower middle income countries. Talk also of the issue of capital flight outside the country, and then the weak accountability mechanisms for raising and managing taxes in lower middle income countries. So this weakness in the tax system of our countries make it a little bit difficult to rely on it as the sole or single most important reason source of financing healthcare. And that is where most nations try to tilt towards labor tax as an alternative. I want to give an example with Nigeria, which has decentralized its health insurance system. We now have state social health insurance agencies in the 37 states of the country. And because of the complex nature of the political economy of Nigeria, this complex federal system makes a harmonious or single tax system a little bit difficult. And so most of these states, they try to resort to labor tax as an avenue to expand. Let me use the word expand here, to expand the fiscal space, no matter how little, at least better than none. And this decentralization is, this complex nature of our federal system is not only an impediment to the tax collection and generation, but also an impediment to a harmonious coordination of social health insurance. So labor tax here tends to be a little bit of the easy way to finance healthcare. There was a point made by Abdo with regards to COVID-19 and the effect of COVID-19 on the economy. For me, I want to say there are two sides to that coin, in the sense that COVID-19 has also exposed the vulnerability of nations. Nigeria depends, for example, on petroleum as a major source of income. And COVID-19 has come and there has been a massive crash in the single most important source of revenue for the country. And so if we're relying on tax as a basis for financing our health insurance, we would have been in serious crisis. So I tell you, the labor tax that we enshrined at the various states level is what actually technically sustained the health insurance system in the country. If we had relied on saying that, okay, tax is the simple, any other alternative source of tax, we could have been in a bigger trouble. So COVID-19 should be seen both as, has exposed both the weakness of the tax system, and also an advantage to some extent with regards to African countries and some countries that rely on this one source of income. Look at also the issue of cost as far as healthcare is concerned. Nigeria as a country is undergoing rapid transition across all angles. Donors are leaving the country or scaling down due to multiple reasons. The high burden caused diseases like NCDs keep increasing as people live longer. Huge informal sector is emerging that is technically very difficult to tax. So funding health insurance through labor tax appears to be a low-hanging fruit, as I said earlier, in our journey towards universal health coverage. This is just some few comments that I wanted to make with regards to the discussions raised today. So my summation, my conclusion here is that we should see labor tax as a complementary source of revenue as far as financing healthcare is concerned. It's an equally very important source of revenue as far as lower middle income countries are concerned. And until and unless those systems are in place for African countries or lower middle countries to collect tax, to utilize tax, and to judiciously distribute or allocate this tax to finance healthcare, we will have to contend with labor tax as an alternative for financing healthcare delivery in Africa. Thank you very much.
Thanks a lot, Kurfi. So some very strong points. So now we are really starting the debate. So Abdo, we have received a lot of questions, and as I mentioned already, several participants say, okay, we understand that's not the first way, the highway to UHC, but could we still find a way to take it as a contribution? So a bit along the kind of arguments made by Kurfi. Just before going ahead, Abdo, there is a question because you mentioned high-income countries who maybe at that time they were not high-income countries, but you refer, for instance, to Europe and so on. You mentioned a lot about this solution not relevant for low and for low middle-income countries. But what about upper middle-income countries? So do you think that that these countries are also on the wrong way when they adopt social health insurance funded by labor tax? Or have you any point on this last group of countries? And then we will move, I think, to the discussion on whether it could be a complementary mechanism.
All right, thanks for the question. You took me out of the paper's focus. We specifically focused on low and low middle income countries because the message is a little bit more obvious. So I was the manager for Europe and Central Asia for the World Bank. Joe remembers he was the manager for health financing in Euro, I think at that point. And we would go country after country that decided after the wall fell down in the early 90s to get rid of the Shamasco system and move towards a Bismarckian system, which relies on labor taxes. So these are middle income, upper middle income countries, from the Czech Republic to Albania to everything in that region. And I have a very simple approach to this. I take the Bill Shaw and Paul Shaw framework, the big slide with all the conditions of success, and I take that very seriously. So if a country, upper middle income, let's say, has a fairly sizable formal sector, relatively low levels of poverty, relatively small size family, well-organized health system for service delivery, then they have most of the conditions for a potentially successful labor tax social health insurance. Of course, when I was the manager, something happened in Europe, the financial crisis. So 2007, 2008, 2009, let me tell you what happened to the insurance funds in these countries, health insurance funds, which had shifted to a labor tax system. Suddenly they were all gonna be going bankrupt. So what happened? The government said, oh, we cannot have those brand new insurance funds go bad. We're gonna have to supplement their needs with an increased contribution from general revenue in the middle of a recession. And so even for countries that had a lot of the conditions for a successful labor tax system for health insurance, the other part, which was interesting, and Joe may remember a situation we have in presentation in Albania. What was becoming more obvious to me was Joe and I were sitting on a panel in a conference organized by, I think, the German Development Agency. And everybody was saying, you know, we need to increase labor taxes to pay more for health in Albania. And it was a certain percentage of the labor tax going to health. But when you look at their tax system and you realize they're also supporting a whole range of health and non-health services by this labor tax, you start realizing this labor tax is getting bigger and bigger and a bigger percentage of the cost of labor, and therefore putting more pressure on countries to not hire people through formal sector, which is a terrible idea. And so even for upper middle income countries, while they have a much more likely potential for a successful labor insurance, labor health financed insurance, they also face the identical problems that Latin America has been facing for the last 50 years of a fragmented system, a system that relies too much on labor and increases the cost of labor. So yeah, much more positive space for that for upper income countries, but you cannot ignore what we know from middle income countries in Latin America about the downsides of that. I'm gonna stop on this one, but the commentators had many interesting points. I'll wait until you tell me when you want.
Yes, I would like to, because Joe is with us. Joe was indeed working a lot with Eastern Europe, so maybe Joe wants to contribute at that point as well, and maybe to Joe as well, because it's as Kurfi mentioned, it's okay, fine. We don't like the labor tax for some of the reasons you mentioned, but we have big problem with other taxes, and the informality is a problem also to collect other kind of revenue for the government. So, and even oil, which should be easy to collect from a country like Nigeria, we can also have a really recession at that level. So, Joe, can you first respond maybe on if you want to share some extra thinking on Eastern Europe, so upper middle countries, and then on the informality of other kind of, when informality is a struggle.
Let me just start actually with Kurfi's question or issue, because I think it's really important, and it's come through a lot in what's been in the chat window about the fact that basically, you know, our countries are not raising enough tax revenue, or it's inflexible and so on. And also, if we already have a labor tax, right, a tax on the wage bill, we're not going to give it up. And I think that the issues have to be practical. Right? There's very few countries, you know, as much as some people have concerns about earmarking, for example, very few countries or very few heads of agencies that receive earmark funds are willing to give that up, right? So I think the main thing I wanted to convey on this is that issues around the source of funds, how much money can be raised, are really far from what people in the health sector can do something about. These are issues of tax policy, not health policy, right? And so if the tax authorities and those advising them, which would be basically, you know, not people from WHO, but from elsewhere, like at the World Bank or IMF, if a labor tax is part of what's deemed to be part of the reasonable tax mix in the country to raise revenues, you know, that's fine. I think the real concern and problems arise with the link of that to entitlement. And in particular, where it's been a problem in some low-income countries and low-middle-income countries, is that, and I think a number of people in the Q&A box pointed to kind of the political dimensions of this, that basically these schemes, when they're started, are often highly visible politically. And yes, it's true, as Kurfi said, that the low-hanging fruit from a revenue collection is the formal sector. But oftentimes, for political reasons, those schemes do not expand beyond the formal sector, because the initially covered groups are much more powerful and able to basically expand their subsidies and benefits rather than generously extending to the rest of the population. So even if we're collecting more money, it's not clear at all that those schemes actually free up other money for the rest of the population. They may be absorbing more of those resources. So I think we have to be concerned about whether these schemes will fragment things more. And while maybe in an accounting sense, adding to the total level of revenues, it may be skewing the overall distribution of those revenues on a relatively well-off group, which is the formal sector. So I think that's a concern. Whether it happens in practice, I think it's a country by country thing, but we can identify, and actually how I got into this issue was a paper I did, actually it was 1996, questioning whether African countries should promote social health insurance for the formal sector. And it was possible that that would free up some resources, but the conditions for this to be pro-equity were really stringent on the ability to bring in other people into that system and to ensure that the prices being paid to providers for those privately insured or for those covered by social health insurance were not much higher than the incomes they would earn working in the public system, for example. So there's a lot of difficult conditions for that type of intervention to be really pro-poor. On the Eastern European side, and I had worked in Kyrgyzstan and Central Asia and part of that and that region for a decade, I think a few things, that they came from systems that were actually, while they were entirely budget funded in the past, they were highly fragmented in an administrative sense. And so in a few countries, and in Kyrgyzstan and Moldova in particular, the introduction of social health insurance, including a small payroll tax, so a small labor tax, actually resolved, because of how they designed it, they resolved a lot of that previous fragmentation, because they used that as a mechanism to then channel the budget revenues that were previously flowing to the supply side for them to flow all into this newly kind of independent purchasing agency. And in that sense, even though from a fiscal perspective or a technical perspective, the labor tax was not necessarily a great thing, the creation of those independent agencies probably would not have happened without the introduction of that small tax as an implementation step. So this is something that in some countries matters. I know, like from what Cor was describing in Cambodia, the health equity funds were established as separate purchasing agencies, not with a labor tax. So it's not something that is always required, right? But in many of the ex-Soviet countries, that is what happened. In others, higher income Eastern European countries, such as Hungary, in the mid-1990s, about 90% of the revenues of the National Health Insurance Fund were coming from labor tax. Now it's about 40%. So they have over time changed the mix of revenue sources, but they're pooling all of it in this agency. And they were adjusting the revenue sources with nothing to do with health, but rather the implications for the labor market and employment. Okay, so there are different factors that go into this. And I guess, and sorry, you can stop me if I'm wandering too much, because I could use all of the 2 hours, of course. But it's that the decisions around the source of funds really are not health sector decisions. I think that's the main thing, that yes, it's an unpleasant reality, and many people pointed to this, that our tax systems don't work well. We're not raising enough money. But it's really the finance ministry, the tax authorities that need to be working on that, to be developing new tax sources, to be looking at broader based things. I mean, a lot of focus now on taxes related to mobile phone usage because almost everyone has them, even in many low income, low and middle income countries. But the issue is, yes, we'd love to have that money for health, but the reality is that these are tax policy questions, not really health policy questions. And our job is actually to make the most and the best use of the funds that we get in the sector. There are demands we have, there's influence we have on that. We're not out of that discussion. We need to ensure we can make a good case for an appropriate share of the revenues. We have a very strong case to make for taxes, changes in taxes and subsidies that affect health. So tobacco, sugar sweetened beverages, fossil fuel consumption, those sorts of things. But on overall tax policy, we're not going to solve the revenue problem in the health sector, right? That's kind of much more of a macro fiscal question.
Agnes, if you are with us, you are from France, I'm from Belgium, and we have a Bismarck model. And I think we like it actually, and especially maybe for one of the points mentioned by Joe, that there is this purchasing provider split. We have a social security which will be managed by different stakeholders, employers, unions, and so on, and it's been quite powerful for our health system and I think in continental Europe we are quite happy with this model and this division of work actually. So maybe people also want social health insurance for another reason than the one we discussed so far. So Agnes, could you elaborate a bit on that and whether it makes sense to make the distinction actually? Are there other good reasons to have social health insurance schemes, for instance?
Thanks, Bruno. This is probably time to really emphasize that there are really two different arguments to look at social health insurance. One is the financing argument and the other one is the governance argument. And they are very different, and they probably, both arguments would lead to different conclusions. And the question is probably the fact that the debate is often lumped together and it needs to be unbundled. That often the governance of social insurance is seen as just a byproduct or an implementation detail of the financing of social health insurance. Whereas I would argue that it is a full feature of social health insurance and it needs to be examined in its own value, in its own good. Let me explain that a little bit more. The way social insurance has built itself in France, Germany, Belgium, the cases that you were mentioning, is as a multi-stakeholder institutional mechanism. So it is about collective action. It is part of the social contract. Certainly, we know historically that the reason social health insurance was introduced in Germany at the end of the 19th century was not a health reason at all. I mean, if only because all the health technologies that exist today did not exist at that time. There were no vaccines, there were no antibiotics, there was no antiseptics, no anesthetics. So the reason that it was introduced was as a safety net and as a social contract. And it was very political because it was also a way to build the nation, to establish a social contract so that there will be some limitation of the progress of socialist ideas among workers, and that workers will be actually taken care of by a combination of action from employers and action from the state. So we need to really understand that the way social insurance has built in Europe is not with primary health objective. Actually, initially it was a lot about accidents, work. It was about rare accidents that had a high cost and were pushing families into poverty. So it was really a safety net endeavor. And what we've learned over time is what is really powerful with social health insurance is the governance arrangements. The fact that over time, these arrangements have matured, they became more complex. In Germany, they have involved local governments, municipalities in a big way. In France, they have involved all sorts of different professional groups and then evolved beyond professional groups, because what is called the mutuals, which are these social health insurance funds, exist, for example, for students. They exist for different segments of the population. And the power of that is the multi-stakeholder dialogue and management of the poor, which is like until today in these countries that have this very strong institutional history of social health insurance, They have very strong institutions that discuss benefits, that discuss quality of care, that discuss payments, that discuss everything that a UHC national scheme discusses. That includes funding and defunding. That includes dialogue on big issues such as ethics. This is what is happening in France with the Estate General of Health right now, the Estate General of Bioethics. So the institutions which have built over more than a century, since we're talking now of more than 120 years, have developed a lot of mechanism to foster collective action and build an effective social contract. And this is where in those discussions on social insurance, and this has happened in the group of authors that put forward this paper, I'm always on the side of saying we should not throw the baby with the bathwater, in saying anything in social health insurance is bad and it needs to be discarded. I would actually argue that all the governance arrangements of social health, health insurance are extremely powerful. The fact that it's not uniquely a state discussion, but that it is a multi-stakeholder discussion with complex arrangements that elicit collective choices and foster that. There is also a very strong partnership in those social health insurance, particularly with professional organizations, and they very much include the question of self-regulation of health workers, with health workers having different types of mechanism and scientists to be part of the conversation. That said, now that I've put all the positive argument, which is a governance argument, clearly on the financing argument, the labor tax is really, the evidence, as Abdo has said it, is overwhelming. And actually, systems, health financing systems in Europe are moving towards that. So what has happened several years ago in France is that the health financing has moved away from the labor tax and move away to what is called the general social contribution, which is a tax with a much broader base that is not only on wages, but it is also on all economic activities, with a very strong equity aspect, since this is a progressive tax. It's paid by people and companies, and it is paid with a very strong attention to not being a burden on low-income households. So we've seen this shift happening. And actually, right now, there is a reform in France which is going towards this shift to become almost complete. So what remains of the contribution of the labor tax is basically the complementary package. But the basic package that is universal is borne mostly now by taxation. So I think that's really the sort of two messages. One, we still have a lot to learn from the governance and institutional aspects of social health insurance. But on the health financing side, I think the case is clear, and we should no longer advocate for labor tax.
Thanks a lot, Agnes. So just to remind that actually Agnes is leading the health systems governance and financing department. So we maybe have here a hint for a future webinar, which would be more focused on governance of health financing. And so, Agnes, there is maybe the title of the next paper could be the case for union governed social health insurance or union co-governed social health insurance. Just want to reflect that in Belgium, indeed, I think we are coming really now to the political economy and the path dependency discussion. And in Belgium, the unions are really representing the poor, actually, to a large extent. If you are unemployed in Belgium, you will access the benefits through the union. So the unions have a strong incentive to be defending really the stakes also of the poorest. And so they have been able to consolidate the social contract. While in many countries, the social health insurance is indeed for the middle class, for instance, for the civil servants. And there we observe countries, even Thailand, we see Thailand struggling really to merge its three schemes. So there is a scheme in Thailand for the civil servants, a scheme for the formal sector, and then there is the UHC scheme covering all the others. And these three schemes are still living apart. And I think this is a problem we see a lot in many low and middle income countries. So maybe the discussion could move a bit on how could we make sure that when there are some social health insurance, when there are some labor tax social health insurance, because in some countries they are there, how could we move them away from just defending the benefits of those who are enrolled, but also try to make them more attentive also to the needs of the rest of the society. So Abdo, maybe are you aware of any experience like that, where a country managed to broaden the political economy representation of the social health insurance? So what is your advice to countries with such system today, and how can they move away from the system actually?
So I'll be very honest with you, that's not my experience, nor is it my interest. Joe, Agnes, and others may have better experience and knowledge. If I may just add a couple of words on what Joe and Agnes said, because I thought their arguments were powerful, but I just want to add some of the comments, take us back to the beginning of this, this is my area of interest and focus. I do not want to go beyond that because I'm not a knowledgeable person on that. So Joe mentioned something which is absolutely critical. Generating revenue for government is not the job of the Ministry of Health or people who work in the health sector. We don't have the skills for it. We don't have the knowledge for it. And we actually mess things up if we engage in a sphere which we have no knowledge. And so I worry when I hear this advice, let's let it be complimentary. It's as if we're ignoring, there's a whole field of expertise that's focused on fiscal issues. And it's an incredibly arrogant for people who work in the health sector to suddenly become experts in revenue generation. We don't have the knowledge, we don't have the skills. It's even worse. When Bruno and Agnes talk about Europe, you are building on 700 years experience with insurance systems before government got engaged. So when Belgium and Germany and others started social health insurance in the 1880s or early 1900s, they were building on 700 years experience with guild insurance systems. And so there was an actual experience with things. Take that to Egypt. So one of the comments coming from Egypt and saying, now we want to take this European model, which has a history and institutional knowledge and negotiation, as Agnes mentioned, and then we're going to put it in Egypt. It is mind-boggling that somehow we take this European-centric model and apply it to a place which has none of the history, none of the institutional knowledge of how to do it. And that's why I worry about the way the conversation has moved, which is let's start with this and then make it better. The other thing which I really want to highlight is, and it's something I believe one of the, I think it was Kurfi who mentioned the term low-hanging fruit. It scares the heck out of me when I hear that term. Low-hanging fruit could be incredibly poisonous. You have to be careful with these statements. So let me close my part of this one by saying, okay, so Bruno, you asked, if you want to do it, how do we do it better? we kept that completely out of the paper because those of us who wrote this paper didn't have the knowledge nor the agreement of how to do it. In my case, I didn't even want to offer it as an option because I think it's a terrible idea for those of us who know what we don't know to suddenly act like knowledgeable on something we don't know. So I will do it because you asked. How I would do this if you force me to give advice to a country to build a labor tax social health insurance. One, I would take out anything that would fragment the system. So if you're going to finance a benefit package, that benefit package has to go to everybody, whether it's funded through this funds coming from the small formal sector, from general revenue, from everything. And they have to be delivered in the same places. So don't make the mistakes of Latin America of building a parallel delivery system to reward those who are paying into taxes. Two, I would ensure that funds are not linked to the entitlements, as Agnes mentioned. So this is money that goes to top up existing funding sources. Three, I would make sure whatever entitlement is given, it highlights cost-effective services, which are mostly preventive, promotive, and not have it be hospital related, which again, will take out complete rationale because those who are going to pay taxes want to be able to access private hospitals or hospitals that are at the high end of it. So there are specific steps you can take. Most importantly, I would worry about the institutional governance. And this is what I want to close on.
Thanks.
Agnes correctly identified that there's two sides of this story, financing and institutional. Please realize most of the low-income countries initiating this do not have the institutions. So you are building a whole new governance structure and you're assuming it's as simple and as easy as passing a tax law. It is not. And so it's not addressed in this paper, but it's my fear is that you say, oh, this is low-hanging fruit, it's more money. But you are expecting somehow low-income countries to start a whole new institution, to staff it, to make sure it has governance arrangements that are transparent. This is a very hard task. So yeah, I'm not a fan.
Okay, thanks, Abdo. I would like to jump on a few points that you made because I think we still have 10 minutes. I think it's important that we keep on thinking in terms of solution. Paul mentioned this blog written by Eric Josephson a few years ago about how we can have to think the scaling up coverage with UHC, and he was proposing a sequencing which would not be by group of population or socioeconomic groups, but a sequencing by functions, actually, a lot along the logic developed by Joe. And so that's maybe something we have to think about, because I hear you, Abdo, but also countries have to develop something. They have to put the energy, the enthusiasm in building something. So I think we have to discuss about the pathway and how they can build things. And I think it's possible to develop some institutions, but indeed, maybe it's easier to first develop purchasing, and maybe purchasing easier to develop than tax collection, for instance, or pooling, for instance. Still, I could imagine that people want also social health insurance for another reason. So Agnes stressed a lot about the distinction between governance and financing, but there is another one. I could imagine also that citizens, and especially the middle class, they are very frustrated with the performance of public health facilities. And you mentioned it, they may want to go to the private sector. So I believe that there is a strong incentive for social health insurance is also this strong desire of people to go to other kind of providers. And indeed, then the way to finance these providers is social health insurance, because they are not funded by the at least from the budget from the government, when the government is still running with a budget. So that's maybe I would like to bring Joe here. Joe, does it make sense, this reflection in terms of sequencing in another way? Does it make sense that social health insurance could be relevant for its capacity to contract the private sector? And do we need also to tailor maybe the social health insurance on kind of top up, maybe some kind of complementary health insurance for an extra layer of benefits on top of the basic benefit that should be guaranteed for every citizen? Over to you, Joe.
Thanks, Bruno. Maybe just before answering, I'm still going to wrap up, right? So I don't know if I'll try to respond on this, and then we'll have some closing things. I think there's lots of issues in the sequencing that are important, and I've only had experience in a few places. Certainly, I think that actually sequencing certain functions is critical, and also that there's a real risk, and I think this is the risk that we've seen with the kind of traditional approach of social health insurance, is that when we start with that low-hanging fruit and we first get in the the relatively well-off formal sector workers or the civil servants with some union power behind them and so on, that we tend to get stuck there, right? As opposed to approaches where we say, we want to design a system for universality. It doesn't mean we can get everybody in first, but what we can do are do things like we can create a unified single information system for the system, that the Ministry of Health has it within its regulatory authority to say that regardless of who's paying for your hospital admission, this will be the data form that is used. We're going to build a nationally unified database or interoperable one. And at least, again, where I'd worked in Central Asia and Kyrgyzstan, having that information system in place as an early institutional step was a critical technical foundation for eventually rolling the budget money into the purchasing agency as well. And actually, as a sequencing of steps, by only in the first few years for this independent purchasing agency, by only essentially paying marginal cost rather than total, they had a chance to develop their skills and systems over a period of years without putting the entire system at risk. So the system remained mostly supply side budget funded, but paying a bit at the margin and so on. Having that time to develop and learn was really critical. And so I think that when we think about sequencing, the information platforms for purchasing are really key. The other is to make sure that there's a real commitment up front to say that given the nature of our economy, ultimately most of the funding will come from general revenues. And if we need to deal with the fragmentation issue by not letting the source of funds actually trigger an entirely parallel health system, right? Including in some cases, even separate providers, right? But saying it's a separate source of funds, but we're working towards putting together our different sources into a more unified system. So there are implementation steps in a more functional way, I think, like that matter, and that can be quite useful when we think about how to move. So I don't know if that answers it, or if you want me to do some wrap up as well.
No, I think thanks a lot, Joe. I think it's indeed time to do the wrap up. So Joe will do the wrap up, and I will conclude the session of today. It's nearly 3 o'clock. So please, Joe. I think it's a difficult task because we covered a lot of things, but I know we all know that you will do it.
I took a lot of notes. I tried it first, as many of you could see. I was trying to manage the Q&A, and like so much in my work life, other parts of life now, much more was coming in than was going out. And I couldn't keep up, and I'm sorry about that. I think one thing this paper shows, which came in some of our answers, and Abdo referred to it, and it's an important lesson for our times, I think, is that people don't have to agree on everything in order to work together, right? So we could still do that and still produce something. I think when it comes to these issues, there's a few messages I wanted to convey. One is around kind of philosophy and history, and we heard some of that, right? And I think it's not correct to say that financing for UHC started with Bismarck in 1883. I think it was financing for social health insurance. The objectives of Germany in the 19th century were fundamentally different from the objectives of Nigeria, Cambodia, or other countries today, right? And as we heard, Agnes talked about it being a safety net. It was taking care of the formal sector. The agenda was industrialization. It was preventing unrest in the workplace and so on. So of course it made perfect sense to have a wage-linked system for the formal sector because that was the policy objective, right? But after World War II and increasingly, and again with the development of medical technology and other things, the aim became universal health coverage. It became the idea of coverage as a right and not merely an employee benefit. So there's really no, at least philosophical reason that there should be employment-based health insurance coverage any more than there should be employment-based education insurance. I mean, it really is a different type of issue, and that the approaches to making and the sequence that was taken from the 19th century to now in Western Europe anyway, don't really apply because the starting point and the policy challenges for the ministers, for the countries are very different. And as Abdo said, we have to be really careful about importing models across countries. So I think that is really important. A second issue, and we heard it, and it's also one of the things that Wagstaff used to talk about, is that when we talk about universal health coverage, we really need to be clear on the difference between coverage as an instrument, which really means affiliation to a scheme, versus coverage as an objective, right? Which is generally what we are talking about, right? Both service coverage and financial protection. Okay, so we can think about this. Korea was mentioned. It's a great example that in 1989, after a very short period of time, they achieved universal affiliation to their social health insurance scheme, mostly through wage-based taxes, but also through some budget transfers for the poor. But in that year, in 1989, of getting 100% of the population affiliated, about 65% of health spending was from out-of-pocket payment. And people were still at high risk of catastrophic expenditure. So as I heard one Korean presenter talk about this, they said universal coverage with health insurance was the start, not the end for them. So I think this distinction between the instrument and the objective is important. I think we heard as well, and really important for making clear policy, that we have to do some conceptual unpacking of issues. And Agnes spoke to that, and I'll just repeat it here. One is the issue, I mean, it's kind of the issue of labor tax as a source of funds versus the issue of linking entitlement to contribution. And those things need to be unpacked. As I was said earlier, right? The tax mix and whether labor taxes should be a part of that is a public policy decision for the tax authorities. It's a public finance decision, you know? And so, but our concern is not so much the source, it's that the flow is stable and predictable as a basis for making effective use of the resources. But the entitlement contribution link is something we're concerned about, right? Because if coverage is a right, then, you know, why treat it as an employee benefit? I think empirically, we also see that where you have high degrees of informal employment, you get low participation, low levels of affiliation. Again, governments step in with very strong general revenue funding to build that in, and the theoretical and the practical experience of adverse selection as well, in terms of people coming in and dropping out of coverage from the informal economy. And certainly what we've seen with COVID and the impact on the labor market. So I think to kind of say, how do we move forward? And I think this was kind of a lot of the comments and questions were about. One is to, you know, and I hate to do this because public policy is often not nuanced, but it does need a nuanced approach. And it's really about how to combine what will mostly be general revenues with non-contributory entitlement and strategic purchasing, and, as Agnes emphasized, representative and participatory governance. And maybe just on that last one to say that for most low and middle income countries, I think representative and participatory governments means not the traditional so-called tripartite governance model of unions, employers, and government, because if unions and employers represent 5% of the relatively privileged population, you have a very unbalanced issue. So it's much more about being representative and being participatory than having those specific entities involved. So this is what we see, for example, in Cambodia with the health equity funds, non-contributory entitlement, general revenues, and output-based purchasing. Even in Nigeria as well, there's some free care schemes in some states that do something similar. It really requires thinking in functional terms. One of my old messages on health financing was that there's no reason a priori where the revenues, the source of funds has to determine how money is pooled, how providers are paid, nor who is entitled to what, okay? And you don't need to have the traditional social health insurance arrangement in order to have output-based purchasing and more autonomy for providers over their internal resource allocation. There's many examples of that. The implications of all of this, and it features very much in our work program, is that the agenda on public financial management is at the core of all of this, because it's about making budget revenues much more flexible, much more oriented to outputs rather than inputs than has been the case in many countries. It's also, I would say, because we have a lot of practical examples of mixed funding arrangements that have some payroll tax and a lot of general revenues, that this led us to lobby for and kind of win an argument a number of years ago to change the system of health accounts, to separate out the revenue sources of a health system from the financing arrangements. Because in the past, we could only see expenditure by social health insurance agency, but you couldn't tell if 40% of their revenues came from general budgets and 60% from payroll tax. Now you can see that difference, and we're increasingly showing that difference as really one of the critical policy issues that can be revealed, and producing much more empirical information on that. So it really is something that if we can think functionally rather than going in terms of old models or labels, we're in better shape. So let me just summarize after all of that. And anybody who knows me knows I like to make speeches. We can know that basically a contributory-based labor tax-led approach won't generally help low and middle income countries very much. It's not going to generate a lot of money. And if entitlement is linked to it, it can drive fragmentation, inequity, and inefficiency. This is a very important lesson from the experience, well-documented experience of Latin America. So general revenues are at the core, but we have to not just throw it at the supply side. We need to be able to use that money well, which justifies the focus both on public financial management and on transparent governance and reporting arrangements. And so most importantly, again, try to think functionally and not in terms of just labels or schemes. Thanks.
Thanks a lot, Joe, for this very rich synthesis, and I'm sure we all enjoyed the session today. So it's 3 o'clock, even a bit more. So we hope that you really enjoyed the session. Abdo, you may want to say a last few words, but I see.
No need. Joe's answer was perfect.
I want also to Kurfi, Por, any last comment, reflection? So thanks a lot, Kurfi and Por, for taking the difficult role of challenging all these great health economists. So I want to thank all of you, all the contributors, for participating on behalf of the webinar editorial board. So we are, as Agnes mentioned, we are a full team organizing these webinars. This was the first one. There will be more webinars like that. So we hope that you enjoy it and you will be with us. Feel free also to propose us topics and also partnership. As Agnes mentioned, our sessions are not organized only by us. We love to organize them with other partners. So this time it was with P4H and with the emerging voices. Maybe next time it will be with your agency or your network or your organization. So thank you, Abdo, Kurfi, Por, Joe, Agnes, and Valerie. We have a discussion forum for WHO on health financing is the HFTN network. I will also share the link of this network. You may want to continue the discussion. We will try to see whether we can make a kind of synthesis of this discussion. And we will also soon set up a mailing list for this webinar series. So for all those of you who want to come back to our next sessions, you may register to this webinar, this mailing list, and then you will be informed for each new session. So thanks, everyone. Have a nice day. Bye-bye, and we hope to see you soon.